Perfect. I think we have our recording running on the background. It is Friday afternoon. We're actually, after this week, at the halfway point of the semester. So time is going super fast, which is, I guess, a positive sign. If it felt like a chore, then probably the time would feel like much longer as well. So we're doing great progress on the course. I do realize that this week has been a lot, and I was kind of thinking afterwards that I probably should have warned you on the chat or on the announcements a little bit more that few systems where we are memorizing a lot of things like skeletal system, and I will be honest, also muscular system in the coming weeks, and to a certain extent also nervous system. There's just a lot of material, and since we're traveling at the twice of the speed of a regular semester, if you wish to think of it that way, it might seem that we're asking a huge amount of you, and I'm not downplaying that. We are asking quite a bit for us to cover, but I think that this class is doing excellent. I keep on track of the grades very carefully, and you might have seen that I'm pretty eager on engaging on the discussions. Obviously, the purpose is that as we progress through the semester, I'm hoping that my role might be a little bit lighter and it's more student driven, but I'm always available. I'm always happy to engage. I'm always happy to answer. I'm also always kind of eager to ask questions when there's something that I can either point out that's interesting or that's kind of maybe not addressed to the same level of detail that I would do in a classroom setting. So we're on a good path, is what I'm saying. I do see some familiar faces or familiar names from our earlier week live online session, and I do see some new names. So first of all, thank you for being here. Do remember that I always give you extra credit for being here, so that's appreciated. I realize that not everyone can always stay for the full time, so you're free to come and go as you wish. Having said all that, I also think it's important that we make the sessions to work for the students in a way that they want it to work for them. So I'm super happy to answer any questions. I'm super happy to kind of delve on any complex themes or complicated topics that might have come up, or just anything really that I can do to guide you on this course. If there's nothing burning, then normally what I've done has been going through the lecture materials kind of in a nutshell version. I give my students often kind of an idea that these nutshell version revisions will get you to pass the course. And then to go above that, they might need a little bit more work. Remember that the assignments, the homework that I give, they're not just something that you should land on and magically have all the answers. They're very much, especially on these online classes, part of the learning process. So if you have to look up things as you're tackling those homework assignments, you're doing it right. The expectation is not that you just magically know it. The expectation is more of that those assignments help you to identify what's important and what's crucial. What else was I going to say? I was going to mention about the discussions. Like I said, I think there's some amazing work happening. And again, this course can be taking many shapes and many forms. My teaching philosophy is that students can engage as much or as little as they wish. There is certain expectation for certain amounts of points, mainly to get full marks for the assignments. But if someone goes above and beyond, I am very, very generous normally with the extra credit, and that's intentional. That allows you then to kind of manage your workload on other possible weeks if you have a week when you know that you might not be able to engage as much. I think it is useful always kind of to check how we're doing. I know last time when we met on Wednesday, I was kind of driven to keep up the speed. We didn't really take a lot of time on just kind of sitting and figuring out how everyone's doing. So I want to make sure that we take a little bit of time for that. And if you see me writing in the middle of our meeting. It's just me taking down the names so that I can give those extra credit points for anyone who's in attendance. If you, by the way, ever notice that I haven't given you points or you have questions about the grades that you've received, I'm usually pretty good about being pretty precise and pretty accurate, but like any person, I'm a human and I would deal with quite a lot of feedback that I provide on these comments. So it is possible that I have some things where it might be worth of me to go and double check. So don't hesitate to let me know if you have questions about your grade, and we'll definitely make sure that it is where it needs to be and you've been receiving points for everything you've done. But I did want to give this moment for anyone who has anything on mind. Obviously, I'm always super happy to hear that if things are going well, but also if there's anything that I can do that would be helpful in terms of what would make your learning on this course better or make it a better experience. My big kind of, I guess, challenge as instructor is that we do collect feedback from students, but we often collect that feedback towards end of the semester, and that doesn't really give us time to address things during the semester. And I think that the big thing for me is that this course can be delivered in multiple ways. So if there's anything I can do, anything I can change, or if there's something you want me to keep doing or do more, feel free to share. I do have certain limitations, I'm going to be honest, also in terms of my workload. This is part of my job. This is a very big part that I enjoy of, but there are other aspects as well. But I will leave the space if anyone wants to share anything, either unmute and just share or drop to the chat. But I also will not be offended if no one wants to share. It's never share or die in my classes. Since I'm not hearing anything, I will try to make sure. It is always a little challenging during summer. The course moves at the fast rate, but I'll try to make sure that we also have a chance for you to give anonymous feedback if that feels easier. I realize it sometimes might be a little strange when your instructor asks you to be honest, but I promise that I've done this long enough that I don't take the feedback personally. I value it. But I'll try to make also some sort of a survey where you can share how things are going. I wanted to highlight this week's assignment. So we're covering two chapters. We're covering chapter 8 and chapter 9. And like few people have mentioned on the discussion forums, I think they flow nicely together. The chapter 8 is kind of a beast of a chapter in terms of the content and volume of the content. So we're looking at the different bones of the body. We're talking about skeletal system first in general, but we'll look mainly different bones and different bone markings on those different bones. For that chapter, I have, as usual, your chapter quiz, practice anatomy, and a discussion. And like in the previous couple of weeks, I'm looking for 2 posts on a discussion forum for full marks. Again, if you don't feel like chatting, if that's not your thing, I won't be offended. But that's kind of what I'm looking for, full marks. If someone chooses to post only once, I definitely will not be chasing after you and be like, oh, you didn't post. That is totally acceptable. You just won't get full marks. If anyone goes above and beyond, we have some outstanding students on this class. I normally try to give a little bit of extra credit for that as well. So again, remember, you choose the activities, you choose the things that work for you and collect points for those. So that's what we're doing on chapter 8. On chapter 9, we're kind of moving, I think it's a little lighter chapter maybe. We're moving on, kind of transitioning from the skeletal system and individual bones towards what we'll talk next week. And we're looking on chapter 9, our joints or articulations. Chapter 9 homework contains your quiz, your practice anatomy, and discussion. In addition, on chapter 9, I do have another food for thought kind of written answer for you. It doesn't have to be a full-on formal essay. I'm looking about a paragraph, kind of discussing what the question prompt there asks about being double jointed. That expression on its own, I think, is a little misleading, but sometimes it's good to unpack the misleading parts and then start to make sense of that. But being double jointed, I think that it ties in nicely onto articulations, and it gives us a chance to look at a little bit of a different angle of the content that we're covering. So for these activities, I'm asking that you would complete them by the end of this week. So Sunday, 1 minute before midnight is, I think, when the assignments close. Having said that, if you haven't already noticed my style or teaching philosophy, I do think that I'm pretty flexible if someone misses a due date. I know that the Connect assignments do lock at the end of the due date or once it has passed, but I am open to reopen those if there's a reason. We'll have that dialogue on case-by-case basis. If you miss a food for thought or discussion, I think you can still submit those. I'll try to regrade those if you missed part, or if you want to send again a different answer to the food for thought assignment. So I'm happy to receive those, obviously within reason. So I'm not looking that on the last day of the semester I receive everything as a resubmission. But if there's need, I'm happy to work on individual basis and figure out if I need to open something or if I just need to go and regrade. If you submit things after the due date, I do generally ask that you send me a message on the Canvas messages, just so I know to go and double check that. I do have a big view of everything that's happening on the course, but it is possible that I don't go always screening of the past assignments into such amount of detail. But like I said, that's what we're doing on this week. I do want to also acknowledge, and I think I sent an announcement of this as well, that initially there was a typo in some of the due dates. So chapter 11 is what we'll be looking next week. So initially it popped up on this week's assignments, but I think that it was quickly fixed. So you do not need to do chapter 11 this week. It's for next week. So that's what I have about the homework assignments. Again, if you have any questions, any comments at any stage, just feel free to unmute yourself, jump in, or if you prefer to chat, whatever works for you. But if it's quiet, I kind of approach it like a wedding, then I assume that everyone's happy and I'll move ahead. Well, in that case, again, if someone has anything that I can help with that's kind of more prudent, I'm happy to explore those things. Or otherwise, since we have some faces that were not necessarily able to join us in the Wednesday session, what I was simply going to do was to go through kind of a nutshell version of the lecture material, if that's familiar to you, if you've already been to that session. If there's nothing new to you, I won't be offended if you drop in or out as you wish. Or if you have questions, if there's something I can help, just jump in. I kind of try to make sure that I give everyone a chance, since it is an asynchronous course. Setting those times when we meet together is always a little challenging. So I just try to offer a couple of chances going through the material. But again, if there's nothing, I'm just going to go through it. I won't be offended if you're like, I'm good, I don't need this. If you want to unmute or chat, I'll take those gladly as well. So in that case, let's have a look of a little bit what we discussed on this week's chapter. So we focused on this human skeleton. And the word skeleton comes from Greek skeletos, referring to the dried up body or mummy. My background, I think, shared a little bit of that. One of the things that I've done in the past has been in fine arts fields and museum studies field. So mummified remains actually used to be a pigment that we used in fine arts as well. So some of the older paintings, you will see that there's a certain pigment that was literally produced from Egyptian mummies. So that's where the term comes from, Greek language wise. But what I really wanted to I always start broad and then narrow down, was to point out that there's many different skeletons, types of skeletons that we see in biology. We're obviously focusing on the human and human skeleton. Human skeleton would be an example of an endoskeleton. Endoskeleton refers to a skeleton that's inside the body. And on top of that skeleton, then we have overlaid soft tissues. You can see a couple of nice pictures there, kind of comparing human anatomy to horse anatomy, but we see that both of these animals do have an internal skeleton that then provides where other things build up on. But by no means is that the only skeleton type that we see in the body. Exoskeletons are what we see often in many insects. Exoskeletons are skeletons that are on the outside of the body. So the analog that I often offer to my students is, think of medieval knights, how they have their armor on top of the body. And if that armor was something that would then give your body that structure, that protection, to other beneficial functions that skeleton does. Kind of expanding on that, we do see that exoskeletons are being used in some other settings, for example, military applications. We do see that there's interest in adding additional protection for the military applications, as exoskeletons also may be strengthening the skeleton in that sense. We see after certain surgeries, or if there's issues like joint damage, we might do either temporary or more permanent exoskeleton option as well for some of the patients. So that's something that we sometimes choose. But in nature, naturally, it would be insects where we would, for example, see those exoskeletons. I also wanted to mention hydroskeleton. Hydroskeleton is what many things like worms or starfishes rely on. This is where we use the fluid pressure inside the organism to establish that skeleton, that structure, framework where everything works from. Obviously, hydroskeleton would be challenged if there was dehydration or issues with the electrolytes, issues with other things like salts that could impact the balance of the fluids in these organisms' bodies and then compromise their hydroskeleton. But many forms of life utilize hydroskeleton very successfully. Final one, kind of looping back to previous weeks when we looked at cells. I wanted to also mention the cytoskeleton. Of course, we see those microscopic filaments and tubules within the cell. Within the cell, especially animal cells, they gave the cell its structure, but also kind of these pathways for materials to travel inside the cell. So that's another type of an example that might be an interesting one of the different skeletons. I think we could continue this list of other skeleton types in life as well, but I try to limit that to my Bio 181 classes, maybe Bio 156, since we are focusing on the human skeleton. I think that that's where we'll leave this kind of a general introduction, and instead of shift the gears and start looking at the most important bones, especially as our main focus on this chapter. I did want to acknowledge some amazing sharing that's taking place in our discussion forum. There's some students present today in this session, and some students who are not present, but I've been very impressed of the mnemonics that you're developing, how you're sharing, how you're prompting each other to consider those things. All of that is exactly what we're looking after on the discussion forums. If you have a tip, if you have a good trick, if you have a thing that helped you to realize something, I encourage you to consider sharing that with your peers. I don't use a curving grading, so everyone can do well if everyone does well in assignments and exams and tests. So you're not among competition. So consider that. Students often find that also makes this course a little bit more enjoyable, building that virtual learning space. So thank you again for everyone who's asking questions, who's answering to their peers, who's sharing tips and tricks. I mentioned as well that if any of you either this week or in the coming weeks, when we'll look at the muscles, skeletal muscles, feels that just interacting physically with models would be helpful, I'm super happy to facilitate that. I am on campus every single day when the college is open, pretty much all day, whether I have time to take multiple hours every day with students, that might be limited. But if you do feel that interacting with models and you don't have access to those elsewhere, it would be helpful. Let me know either by messaging me directly on the Canvas or by posting on the discussion forum. I'm happy to see what we can do to help you. We do have great resources like a learning center available for you, where they have pretty much every single model that I would use in a classroom setting for students to go and independently interact with those. So just putting that out there, but that's not an expectation, that's not a requirement. But I'm very, very impressed how you're working and how you're making the online setting work for you. So let's start going through the meat of the chapter, if you wish to speak in that figurative language, and have a look of different bones. I've divided the bones into sections. I believe that making them in manageable chunks is often more helpful for students. So I was going to start with the axial skeleton. Axial skeleton consists of 80 bones. We won't review each and every one of those, but we'll have a look of the most important ones. So we'll divide the axial skeleton into a skull, the vertebral column, and thoracic gauge. I do want to mention at this point, again, you'll notice that there's certain themes that I keep bringing up from one chapter to another, that remember all these systems are interlinked. And the work that you're putting in to learn the skeleton this week is going to pay off when you move next week, when we'll look at muscular system and skeletal muscles, and we'll see that all those bumps, all those structures of the individual bones that you're learning are actually often either attachment points for the muscles or otherwise helpful. I think many of you, again, on discussion forum have pointed out that the terminology you learned about the body regions is actually now becoming very useful when you're seeing the bones that are associated with those. So let's have a look of axial skeleton a little bit. Well, axial skeleton forms multiple different functions. I've highlighted 3 here. So we see that first of all, the axial skeleton forms your body's long axis. So one way to study anatomy and physiology is to kind of oversimplify first and then add the detail on top of that. So one way to consider the body is that human body is kind of like cylindrical structure. It is that axial portion that's the cylinder, and then we have things that attach to that cylinder, like your upper and lower limbs. You can live without upper and lower limbs, but pretty much most of the structures within that cylindrical axial skeleton are crucial, are vital for just simply staying alive. The other thing that I wanted to mention about the axial skeleton is that axial skeleton actually provides attachment points and supports the head, neck, trunk, limbs. So it's really, really important in a sense that not only does it house the vital organs, but it's where other structures from the axial skeleton can build up on. So we talked about that, how the internal skeleton was attachment points for the soft tissues to be laid on top. One of the things I've done in the past, again, in the, working with larger museum objects, mainly buildings and statues, we often use scaffolding around when we work on those. So that would be an example of exoskeleton, but the scaffolding in case of the axial skeleton is really where everything else can build on top of that. Finally, the third function that I've highlighted here, I think I've already alluded to that many of our vital organs, like your brain, your spinal cord, your heart, your lungs, and why not also urinary system, and to a certain extent, reproductive system structures, are housed inside the axial skeleton. Abdominal as well, there's less bony structures around that. But if it is a really important body part, we typically tend to enclose it inside a protective structure. So the brain inside the skull, heart and lungs inside the thoracic cavity, urinary reproductive organs within the pelvic space. So we try to provide that bony protection for these structures as well. So I hope that that kind of helps to put together, first of all, kind of like a little bit of that why when it comes to the physiology. We're going to start with the skull, and we'll see that skull consists of 22 bones. This is probably the most complex series of bony structures in the body, and we can divide these bones into two main groups. So our cranial bones, these are responsible for enclosing the brain, so the cranial cavity. This is where what also serves important roles, these bones, for attaching as attachment points for the muscles of the head and neck. And then we have our facial bones. This is really kind of, if you think of anterior portion of the skull, whereas the cranial bones represented the rest, if you wish to use directional terms. The facial bones serve as a framework of the face. This is also, these bones, important to contain many of our special sense organs. So your eyeballs for the sight, taste, so the oral cavity structures, why not also nasal cavity structures for the smell. I would even highlight mid and internal ears. They would probably fall more to the cranial bones than to the facial bones, but we'll see that this bony framework really protects those very sensitive sensory organs. Other things that I would mention about the facial bones, we see this is the passageways for not only for the food, but also through the air to pass into the body in case of the air also out of the body. And obviously as well with the facial bones, we see a large number of facial muscles of facial expressions that are really, really important for us. We'll talk about those next week, and we'll see especially that the facial muscles play a crucial role in how we communicate in our modern society. If you look at the skull at large, many of these bones are flat bones, and they are interlocked, especially in the cranial vault with these sutures, and we'll talk about those sutures a little bit more. These are kind of like kind of a tooth and peg or pin and peg like attachments that are very, very form rigid joints, holding those together in a mature adults. But let's start with the cranial bones. And from the cranial bones, again, I've provided, I think, quite a few handouts on your materials. So if you enjoy coloring structures or coloring diagrams, those should be available. If you need additional ones, let me know. I'll definitely find you more. But if that's your learning style, it might be useful to revise each of those bones, kind of follow where they're found, try to figure out where they're related, what other bones they join with, and so on. But the cranial bones, we have some where we have only one of those and a lot of paired cranial bones. We see that these can be divided into a vault, which is really forming, I guess, the superior, lateral, posterior, and why not a little bit of the forehead portion of the cranium, and then the inferior portion of the cranium formed by the base of the cranium. So really creating that empty space where the skull can be protected, or the brain can be protected inside the skull. Remember, brain is basically just fatty nervous tissue, so it's incredibly vulnerable, not only for physiological imbalances like toxins. That's why people get drunk when they consume alcohol. That's why using drugs, whether it's recreational or prescription, that alters your nervous system function. So the nerve cells are incredibly vulnerable, fragile. But similarly, I would say also physically, blow to a brain, injury to a brain, impact to a brain could be an issue. So that's why we have this cranial cavity, and the brain sits in a liquid there. So we kind of protect that. So I guess that those were the cranial bones. If you're interested, we can go those one by one. So we have our frontal bone, parietal bone, occipital bone, and temporal bone. Those form the regions of the head that we've been talking about earlier on. From the temporal bone, I would highlight the opening to the mid and inner ear, and also the where the mandible articulates at the temporomandibular joint. You'll also see that we have some bones that are more of a single bone. So we have a sphenoid bone that extends. Most of it is actually going to be inside the skull. So we only see a small amount on the side. And a tiny piece of ethmoid bone is also visible. So a lot of time when I study skulls with my students, yes, studying those models of the skulls is super useful. And then we probably pull out some of the disarticulated skulls as well to really appreciate what's going on inside. So if, again, that's something that you feel like you would benefit from, consider those other virtual resources that come with your textbook. And if you want to come and interact with those, I totally can do that as well in person. I wanted to highlight from the base of the cranial cavity also that we'll end up seeing multiple openings, and not all of them are visible from this angle, but there's a bunch of openings. So this is, or in fact, we'll see 85 individual openings. I've counted them in the past. And this is where we see important structures like your spinal cord, as a continuation of your brainstem coming through, the foramen magnum, which literally translates from Latin term for the big hole. But we'll see others, openings going to, like I said, to your middle ear, inner ear, but also to nasal cavity, your cranial nerve, that's olfactory nerves. Your first cranial nerve, we'll talk about those later on this course, actually enters to the nasal cavity through this space where we have multiple little holes on top of where the nasal cavity's roof would be. Similarly, many important cranial nerves, others pass through these openings, also blood vessels, and so on. So a bunch of things. We can call these indentions that we see either foramina or canals or fissures. There's multiple functions for them. And further you go in your study, I think especially on 300, 400, and maybe even 500 level classes, you'll get to learn each individual hole and what passes through them. Having said that, I will kind of take a side tangent of what we've been discussing and just mention I see some great questions also on the discussion forums. Happy to answer, happy to expand. Do remember that this course is simply about a normal, healthy young adult that provides you the basis to understand the pathologies, and you will get to take your patho classes later on. But again, if there's interest, I'm happy to talk always about pathologies, but that's why I emphasize what's normal, because that's our goal for this course. In terms of the sutures that I mentioned earlier on, these were those interlocking junctions of the skull bones. A couple of those I'll highlight. So let's start with coronal suture. Coronal suture separates your frontal bones from your parietal bones. So it runs roughly within the coronal plane of the body. Remember how you would put on a crown. So that's that suture there. You also will have your sagittal suture. Sagittal suture separates your parietal bones to the right and left side, so running in the middle. You'll see your lambdoid suture. Lambdoid suture separates your occipital bone from the parietal bone, and why not to a certain extent also from the temporal bone, kind of drawing the line there. And then we have our squamous suture, or sometimes known as squamosoidal suture, separating the temporal bone from the parietal. So those could come up in your practicals. I wouldn't be surprised if they come up even in your practice anatomy. So something to keep on mind. In terms of the bones of the face, facial bones, I think that here I want to highlight there's 14 of them. Some of the most important ones, let's start with mandible. If you look at it individually, it's kind of a U-shaped bone from the top. So not just the chin, but everything else of the lower jaw. We have our maxillary bones, two of those. Just above the jaw, forming the majority of the face, are zygomatic bones on both sides, really contributing to the cheek structure. Some people have very high cheekbones, and that will then appear on their facial anatomy and external anatomy that we see. Some people also in cosmetic surgery might want to alter this side. Your nasal bone forming the bridge of the nose. Remember, rest of the nose was cartilage, but the bridge is actual bone. We have a bunch of smaller bones as well that you'll see. So we have our lacrimal bones, palatine bones, vomer, and inferior nasal conchae. So a bunch of small stuff there as well. But all of this coming together like a perfectly put piece together puzzle, forming the skull, forming the facial structures, protecting organs, and so on. In terms of our mandible, I wanted to highlight from the mandible a few different portions. Whenever we talk about an organ or a body part and it has a kind of a major area, we call that the body of that organ. So body of the mandible would be here. We'll see the angle of the mandible, where important muscles like masseter muscle join. More prominent sometimes on males than on females, but again, there's individual variation. It is really the muscle that we often see, not the bone per se. Ramus is the portion going upwards here. We'll see that we have a notch of the mandible, and on both sides, more anteriorly coronoid process and posteriorly condylar notch, kind of a condylar process, these parts that extend up. And it was this where we really saw the temporomandibular joint that articulates, keeping the jaw with the temporal bone, allowing us to open and close. That can wear down as well. There's been some studies where we've seen that some people have more worn down temporomandibular joints than others, and you can kind of figure out the reasons. On the discussion forum, there were a couple of really good mentions about various different holes. These are important ones for nerves, blood vessels, and so on to pass through. And one that I didn't mention earlier on, notice also how the teeth, the root of the teeth, anchor into the jawbone, and this area where the root of the teeth are entering into the jawbone is known as our alveolar process. The reason why alveolar process is worthwhile to mention if anyone's going to a dental field, we talked earlier on how bones are constantly regenerating and being broken down and built up again, and we needed certain amount of physical stress to strengthen those. Well, this is exactly what happens at the alveolar process as well. If someone loses their teeth, and say we have to extract those or they just fall out, also this alveolar process starts to disappear because there's no longer that stimulation to maintain the bone mass there. So that's why we tell often people that do get those dentures, because those dentures still keep pushing pressure onto this bone and keeps maintaining that bone. But if you see a person who doesn't have teeth, and they take out their dentures, their face seems to collapse altogether. And it is because there's literally physical bone loss as the alveolar process disappears. I think that that's all that I was gonna say about the skull. Like we saw, there were many openings on the facial bones. Nasal conchae are outgrowths from the wall of the nasal cavity. So if I do a really quick, not necessarily the prettiest sketch, but we can do that still. If this is your nasal cavity, from the lateral parts of the nasal cavity, we have these protrusions that come out, and these are our nasal conchae. And these are actually really important, and you'll get to explore a lot more of those on your BIO202 class. But what they do, they increase the surface area of the nasal cavity so that we have as much of that wet, sticky tissue, that nasal mucosa, to really interact with the air that passes through there, removing any impurities of that air, also humidifying it, and also heating it up. So that's why we have the nasal conchae. What I was going to do next, if that's okay with everyone, I was going to talk a little bit about the rest of the bones. Let's start with hyoid bone. Hyoid bone is located inferior to the mandible at the neck. It's one of kind of interesting bones. We don't see too many of these in the body, but it doesn't articulate with any other bones directly. So it's the soft tissues that hold it in its place. It does have a forensic relevance in terms of if we look at signs and symptoms of strangulation, we often look for hyoid bone. Is it intact? But it's not a dead certain clue. It's just something that we consider. You can strangle someone without breaking their hyoid bone, or hyoid bone could cause a break for other reasons than strangulation as well. Within the hyoid bone, again, we'll see that majority of the bone is body. We have two horns, more anteriorly lesser horns, and then posteriorly the greater horns. Important attachment points for soft tissues. I guess I'm going to mention at this point about the paranasal sinuses. Remember the term sinus referred to an empty space, if you wish. So these paranasal sinuses are sinuses within the nasal region. These are empty spaces within the bones of the skull. The purposes are some agreed, some debated, but we know for sure that having these empty spaces reduces the weight of the skull, also kind of help with voice resonation. There's some other theories that maybe they help with the collapse of the face, kind of absorbing forces, or we know that they have a role with the immune system. We've all heard about sinusitis, inflammation of the sinus, but we don't quite know how. We named these paranasal sinuses based on the bones where they're found. So above the orbits, your frontal sinuses, then below your maxillary sinuses within maxillary bones, sphenoid sinus, kind of deep. We can only see part of the sphenoid bone, but it's deeper in the skull inside. That's where you find that space. And then series of ethmoid sinuses interconnecting behind the nose. Since we have some folks who have already heard me talk about this, I'll add a little bit more, but again, this is not in your exam. I've done quite a bit of work in the past with individuals who in cosmetic surgery field, but also individuals, and terminology has changed. So do know that I don't wish to be offensive. At that time, we talked about gender reassignment. I think these days we would talk more about gender confirmation surgery. But some people who have, for example, very male-like skull characteristics might wish to soften those to make them more feminine. And in those surgeries, we do actually peel the skin and soft tissues of the skull and can shave down some of the bones to make them less masculine in appearance. If we do that, there is a concern that we always have that we weaken that bony structure, and now the sinuses are going to be closer to the surface. So any injury to those, whether it is in an accident or impact accident, or whether it's in a say physical altercation, these people have far greater risk of their skeletal structures of the face collapsing if they get an impact there. So something to keep on mind. But again, I think that medicine is one of those things where we balance multiple factors, and sometimes confirming someone's gender identity can be one of the risks that come with that. So that was just a kind of a side tangent to highlight about paranasal sinuses. Next thing that I wanted to talk about is our vertebral column. Our vertebral column, you'll hear in many layman's terms, spine or spinal column. We'll see that the vertebral column runs from the skull all the way to the pelvis. And if we go backwards, actually, we'll see, I hope I have a good picture, we'll see the attachment points of the first couple of cervical vertebrae. Notice also on this that any of these bumps are attachment points of important muscles. So going back to where we were, what we see here is that the vertebral column plays two important roles, transmitting the weight. And if you think of the human body, we actually end up adding more and more weight as we go down the vertebral column from your head, upper limbs, elsewhere. All that travels down your vertebral column, which then at the very end transmits the weight to the hips, from where the weights are then transmitted to the lower limbs. But vertebral column, it does deal with a lot of weight, and for that reason, you'll see that the body of individual vertebrae increases as we go down the vertebral column because they are dealing with greater forces. Other thing that's worthwhile to notice about the vertebral column is that inside there, within these empty spaces that we create, we have our spinal cord running. So we're protecting it with these bony structures around it. And this is why sometimes if we have an injury of the vertebral column, we're very, very worried of the spinal cord inside it, because if you injure the spinal cord, that could then lead into paralysis downstream from there. So important role definitely to consider. Other thing that I wanted to mention, vertebral column provides many attachment points. We'll see on the thoracic vertebrae attachment points of the rib bones, but many other structures as well, and many muscles and so on. So we're going to see 26 vertebrae that form the vertebral column in total. You would describe them, if you wanted to, as our irregular category of the bones. To do our life a little bit easier, we'll simplify the vertebral column into 5 different regions. So we have our cervical region, 7 vertebrae there, thoracic region, 12 vertebrae there, lumbar region, 5 vertebrae, and then we have our sacrum and coccyx. Both of those start as a different number of individual bones that then fuse together. Notice coccyx, our tailbone. Obviously, we don't need it anymore. It's an evolutionary remnant. So something to consider in that sense as well. Sometimes students struggle to remember the number of vertebrae in each region. So what we do, at least I think American pattern of eating is a little different, but in Europe, we would consider the eating times, food times. You eat your breakfast at 7, lunch at 12 noon, and dinner at 5. So maybe that helps to remember the number of those. I don't know. Kind of again, expanding a little bit, you'll notice that vertebral column has multiple curvatures. And this is not the case when you're born. Newborn's vertebral column is kind of C-shaped arch. And this is by all this process of learning to first crawl and then learning to stand up is really a big developmental goal. And often we just think that, oh, it's all about balance. It's about far more. The baby is actually learning to create these curvatures to their body. This comes from lifting the head. At about 6 months, the muscles strengthen. We're starting to formulate this curvature at the neck. Similarly, the crawling and eventually standing up around at 9 months, we need to have these curvatures formed so we can get this balance, distribute those weights, and so on. I did last time when we met and talked on Wednesday, think about that a little bit, that I didn't go necessarily into quite a bit of detail about these curvatures. There was a question on the chat, so I'm just jumping a little bit there. One of the questions on the coccus that is more curved, it was on female and male, which wasn't on the PowerPoint, on the practice quiz or assignment. So I would have to go and look at that. We will do that probably at the end, but I appreciate, first of all, you to ask. So we definitely see male and female anatomy differences. Let me unpack that a little bit, and then if I don't get to the to the answer, let's have a look of that quiz at the very end. And if you have to go, you can definitely come back to that recording. But remember that the big difference between males and females is all about the giving birth. So that's why female pelvis, which then, if we think of consequently the sacrum and coccyx as well contributing to that, even though they're not technically part of the pelvis, would need to be adapted to that. So we see female pelvis often bony structure-wise being wider and also having larger opening for facilitating that passage of the baby. So I would imagine that the curvature would be in relation to that to facilitate the passage. Let me think about that a little bit, and we'll definitely come back to that. I'll make a note for myself also. I'll post an announcement of that. In your quiz. So I'll definitely have let's unbundle that towards the end of the session. I'll go actually to the actual quiz. We'll have a look of that question together, and I'll also make sure to make an announcement of that. Thank you for asking. A very, very good question. Other things that I wanted to mention about the vertebral column, the first 7 ones forming the cervical portion of the vertebral column. If you look at the individual vertebrae, these are relatively small, especially the atlas and axis at the very top, the 2 most superior ones. These 2 most superior ones actually contribute to your head movement, so either yes or no movements. They're dealing with some amount of weight, mainly the head, but it's not a huge amount of weight that they're yet carrying. But as we're moving downwards to the thoracic vertebrae, we'll notice that especially not just in general the vertebrae, but especially the body of the vertebrae gets larger as we're moving further down. This is because we're dealing with more forces now, but also these articulating facets of the vertebrae become more prominent, so we have easier time attaching to those. Moving even further down to the lumbar region, now we see really massive bodies of the vertebrae, so they deal with a lot of weight and stress, so they're really kind of blocky in appearance in that sense. And I think that we already discussed about the sacrum and coccyx. Remember with the coccyx as well that it's an evolutionary remnant. It really doesn't serve a purpose these days anymore. But we have some of these. Another one that you'll see is our appendix that we still have. But if you give it several hundred years and we're an A&P student, you probably wouldn't need to learn about anymore. But for now, we'll learn. But yeah, I'm thinking of your question. And like I said, we'll come back to that. I want to make sure that I address it. I'm thinking it on the background. What else? Perfect. What else? I was going to mention also about that vertebrae, these individual vertebrae don't interact directly with each other as bony structures. In between of those, we'll see what's known as intervertebral discs. These are cushion-like pads that contribute to the mobility of your vertebral column and also to your shock absorption of these forces. Because they are connective tissues, soft tissues, so to consider, we do also see that under stress, they do actually give in over time. So if you measure a length of a patient at the beginning of the day and end of the day, you will see that they are a little bit shorter at the end of the day because these intervertebral discs have been pressured and kind of compressed. But I put, I guess, this slide here was to highlight. Here we have a really nice picture. I think it's a CT picture showing us a herniated disc. So a disc that's bulging out, and this could be due to a physical trauma. And what often happens is that might end up pressing the spinal cord or a nerve, and this could cause issues. Pain is pretty unbearable. We had some discussion about that also at the discussion forum. Treatment to herniated discs really varies on the severity, how the patient presents and how they're able to deal with it. Anywhere from exercising, strengthening that area, massage, heat, painkillers. But also in worst cases, we do have to consider surgery as well. So that's kind of, I guess, what I wanted to highlight there. I didn't go into that, but since I do know that some students are interested about pathologies, one of the things that is a prompt that I threw to the discussion forum is a condition known as scoliosis. So where the curvatures of the vertebral column are not the way they should be, there's abnormal curvatures. And these often occur during the growth spurt. Mostly they're fairly mild, but can get severe as one ages, and they can become very, very painful and disabling. Treatments, again, vary based on, of the scoliosis, vary based on the severity, whether it is, we see sometimes in some patients, braces to kind of try to realign, or in more extreme cases, surgery might be needed. What else? I was going to mention here the typical, just an average vertebrae. Obviously, the proportions vary depending on which vertebrae we cut. Okay, chart and textbook page. I'm just following chat for anyone who's watching the recording. Page 75, section 8.5. Let me have a look of that. Thank you, Jason, for sharing that. I think that that's exactly what we need. Again, I have to applaud a great peer support, and like I said, we'll visit that at the very end, but this was amazing that you were able to help your colleagues. So page 75, section 8.5 apparently is a good help. Great peer support, great work together. So we'll visit that at the very end, but sounds like we've got some great tools there. So about these typical vertebrae, important structures there, the largest part that carries the weight is the body portion. We do have a foramen there where the spinal cord would run in, and then we have various different processes. So we have our spinous process, and then we have our transverse processes. Notice also how we do have these articulating facets for the bones that connect to these individual vertebrae. You would call this part where we're moving from the body to the transverse process, actually a peduncle, and then the portion from the transverse process to the spinous process as lamina. So bunch of terminology there as well. But yeah, the comparison of a male-female pelvis, kind of, I'm jumping a little bit, sorry about that. I used to have a food for thought prompt about comparing male and female skeletons as well. And on that time, we did unbundle quite a bit of the differences, not only in pelvis, but elsewhere. Pelvis is a really good bony structure to tell differences. So that's definitely worth looking at. I'll have a look if I will throw back that discussion later on, so that allows us to unbundle that a little bit more. What else? Let's talk a little bit about the thoracic gauge. So thorax is the term that you'll see used. This is really attaching to the vertebrae within the thoracic region. The parts that we're going to see are going to be our ribs and our sternum. The functions of the thoracic gauge really to protect the vital organs housed inside, so heart and lungs, supporting your upper limb joining to the axial skeleton, so your shoulder girdle and their attachment. There's actually, interestingly, from the upper limb, the attachment, the only bony attachment to the axial body is through your clavicle, through your collarbone. In addition, we see that the thoracic gauge provides many attachment sites for muscles, and these muscles are going to become far more familiar to you next week, but muscles of the neck, back, chest, and shoulders are going to be important here. So let's have a look at individual bones of the thoracic region. First is going to be our chest bone, so sternum. And this is, I guess, sometimes in layman's language called as our breastbone. With the sternum, notice that it's divided into three portions. Most superiorly, we have our manubrium. So this is going to be a term that becomes useful when you look at these different junctions, like clavicle joining to the manubrium. The largest part of the sternum is going to be the body. And then we have xiphoid process at the very inferior portion. On Wednesday's session, I was talking a lot about xiphoid process, that in some patients we see that it might be pointing outwards or it might be pointing inwards, and that can become an issue as a risk factor of damage. But on most people, that's not really an issue. Interesting fact about the xiphoid process, we'll see that it's only fully ossified at approximately 40 years of age. So really skeleton again. A lot that we can do in terms of determining the age of the person if we find skeletal remains, but also very much of a set of structures that keep developing throughout our life. Sternum, that is the part that we wish to depress during CPR, so that we're kind of artificially compressing the heart as well to cause some movement on the vasculature, even if the heart is not fully pumping the blood anymore. In terms of the ribs, we're going to have 12 pairs of those, so 7 true ribs. True ribs are defined as attaching directly to the sternum, as you can see here. We also have 3 false ribs, as you can see here. The false ribs don't join directly to the sternum. They kind of bundle together and then join. But they first kind of fuse together. And finally, 2 floating ribs, the most inferior ones. Floating ribs don't attach at all. Individual rib, we could see different parts on an individual rib as well. Head, which is the posterior end, shaft, which is most of the rib, and then the neck just after the head, and tubercle, which is the lateral to the neck, kind of a knob there. So important parts in terms of articulating with other bones, and important parts for muscle attachments as well. So those were what I was going to mention there. What I was going to do next was to talk about appendicular skeleton a little bit. Appendicular skeleton covers our upper limbs, the portions that join them to the axial skeleton, so your scapula and clavicle, and also your lower limbs. And then there we're paying attention to the hips as it joins to the axial skeleton. These junctions of the limbs to the axial skeleton are known as our girdles. So we have our pectoral girdles for the upper limbs, and for the lower limbs, our pelvic girdles. We're going to start with the pectoral girdle, so the shoulder. Again, some excellent discussions on the discussion forums about how we see that these bones that are involved here, so your scapula, so your shoulder blade, and your clavicle, so collarbone. A humerus technically is not a part of the pectoral girdle, but it contributes. So we're going to talk about that, the head of the humerus. They really attach the upper limb to the axial skeleton, important muscle attachment sites. But if we look at these bony structures, the socket is very small and the ball is very large. So this means that we have a very large range of movement for our upper limb, but very poor bony fit there. And for this reason, we need soft tissues that secure the shoulder joint on its side. And it's going to be especially the muscles of rotator cuff that we'll talk about next week that kind of secure the shoulder joint. But we do see injuries of shoulder joint, especially in sports, high impact sports. This bony structure really doesn't hold well together if there's great forces acting. The huge range of movement, I think I asked about that as well. We see that that's obviously consequences of evolution, moving from being four-legged animal to two-legged ones that freed our upper limbs and then made a lot of possible of the human evolution to what we know now as a modern human, the ability to manipulate objects, for example. This joint to the scapula, in the part of the scapula, that's the socket, is known as our glenoid cavity, and the part of the humerus that joins to that glenoid cavity is the head, so that forms the glenohumeral joint. Again, notice the large head, small socket, large mobility, poor stability. We'll see, like I said, some ligaments added to this strength, but it is mainly the muscles that hold it together. With the scapula, I wanted to highlight one thing that often goes amiss when we kind of studied this, is that scapula is not actually directly attached to the axial skeleton. So the scapula and the ribs don't physically connect. There's actually muscles in between. So it is held on its place just by muscles. The only bony connection to the axial skeleton was through clavicle. When we transmit forces from the upper limb, say that you fall and you extend your arm and try to catch yourself, the weakest bone is going to be your clavicle. So you will see that that's often the bone that gets fractured. So from the scapula, I did want to highlight a couple of parts. Let's discuss first in general. It is a thin bone. It's a triangular bone. It would classify as a flat bone, attaching to the rib cage on the dorsal side between the ribs 2 to 7. We see really three borders. We see a superior border, which is a short and sharp in its structure. We see the medial border, which runs really along the plane of the spine, and then laterally kind of this angled border. These actually give us three angles of the scapula. So our superior angle, our lateral angle, and our inferior angle as well. So we can see that we start to kind of then separate based on those borders, the different parts of the scapula as anatomical landmarks. A couple of other things that are worthwhile to notice of the scapula, and I think that we already discussed about the glenoid cavity, the socket portion, being very small against that ball, creating large mobility, kind of unstable in bony structure. Sometimes referred also with the term fossa because it is glenoid fossa, so the depression on the line of the bone. Other things to notice from the scapula, if you're looking at the individual bone, I think that the spine is always worthwhile to talk about. So the ridge on the posterior side, separating our superior and inferior regions, so supraspinous fossa and infraspinous fossa. These are going to be important when we talk about muscles that attach to these regions. What else can we see? We see also acromion, the most lateral of the projections. This is actually where the clavicle articulates with as an acromioclavicular joint. And then we have our coracoid process as well, projection on the more anterior side. This is, for example, where biceps brachii muscle would join. We talked already, I think, that the supraspinous and infraspinous fossa, we would also see our subscapular fossa on the side interacting directly with the ribs of the thorax. So a bunch of things there to notice about the scapula. Again, we're scaffolding, we're building up as you learn these regions. It makes it easier then to understand the muscles where they join. Next, I was going to talk a little bit about the upper limb, 30 bones that are involved there. Luckily, the wrist and hand are where most of them, 27 are, so maybe not as overwhelming amount to learn. Let's start with the humerus. Humerus is the longest and largest bone of the upper limb. Some parts to know from the humerus, we have our head portion at the proximal end that articulated with that glenoid cavity. And we'll also see greater and lesser tubercles, so greater, larger, lesser, smaller. These are the bumps at the lateral proximal and rotator cuff muscles attaching there. One thing that sometimes my students find a little confusing is that we'll actually see two different necks on the humerus. So we'll see what we would describe as an anatomical neck of the humerus, but we'll also see what's known as a surgical neck of the humerus. The anatomical neck separates the head from the rest of the humerus, whereas the surgical neck is really where the fractures typically take place. So a little bit, again, from what profession you ask in terms of what kind of an answer you get of different parts. Other parts that we see this little bump here, kind of halfway down the shaft. This is known as our deltoid tuberosity. So the deltoid muscle would attach here, wrapping around the shoulder, then kind of just giving you a heads up that that's going to come up next week. We'll also see radial groove, where we'll see the radial nerve running into. And at the distal end, we'll see then trochlear, epicondyle, the most medial and lateral ones, important muscle attachment points, and then capitulum, and the anterior lateral side, forming the joint of the elbow. I'm trying to think if there's anything else from the humerus, but I think that that's a pretty good amount. In terms of thinking of the humerus, then joining with the ulna and radius further down the upper limb. Notice that elbow is highly complex joint. We'll study that in detail a little later, but anatomically it would be multiple joints that actually come together. We have 3 bones that all articulate with each other in unique ways. So let's have a look at the forearm bones. So we have our ulna. That's the medial one, and remember medial in terms of person who's standing in an anatomical position. So that's why the anatomical position was so important to learn. Within the ulna, we'll see things like the olecranon process, the cup-like portion that grabs the trochlea of the humerus on the posterior side. We'll also see coronoid process also articulating with the trochlea of the humerus. What else can we see? We can see radial notch where the ulna and radius articulate, and same at the distal end. radius on the kind of lateral side, so on the thumb side, whereas ulna was on the pinky side. There we see the head portion that articulated both with the humerus and ulna, and then the radial tuberosity as well, bump, which is important, where the biceps muscle attaches to. Remember that the bones, ulna and radius, when you're in anatomical position, they run kind of straight along each other, but when you're turning your head or turning your arm, they actually cross across each other. So again, kind of highlighting why it was so important for us to learn that anatomical position. From the hand, we'll see the wrist region is made of our carpal bones, 8 important bones there. If anyone's interested, we can go through them. They're going to be our scaphoid, lunate, triquetrum, pisiform, followed by trapezium, trapezoid, capitate, and hamate. Would I expect you to know those? Probably not. If you needed to know those, you could always check them up. I also kind of struggle to teach the carpal bones to students without an actual model. They're very three-dimensional, so these pictures don't do justice to their shapes and structures. We'll actually, interestingly enough, see also that different individuals have different kinds of carpal bones, so a lot of individual variation there. We teach you just averages on this course, but you'll get to see that there's a lot more variation as you move ahead. From the hand bones, we'll see the metacarpals that really form the palm region, 5 bones there, numbered from the thumb to the little finger as 1, 2, 3, 4, and 5. And then we see our phalanges, which form our fingers, 14 bones in total, again, numbered in the same convention. Remember, thumb was our pollex, and then we have our digits, 2 to 5. Running towards the pinky finger there. So I hope that that's helpful. In terms of the lower limb and transitioning to there, let's have a look of the pelvis. Hips are made of really of 3 different bones, so and sacrum that we have articulating with those as well. In terms of the pelvis, we talked a little bit that there's differences between males and females relating to the childbearing in terms of, for example, the size of the opening of the pelvis so that the baby can come through. Also the pubic symphysis, the angle that we see underneath, which is known as pubic angle. Is definitely different on males and females, so that's one of the characteristics that we use. The 3 bones that make up the pelvis were our ilium, ischium, and pubis. Ilium is the most superior one. Ischium is the bone that you would be sitting on, and then pubis more anteriorly. I guess. In terms of the individual structures of the pelvis, the socket that we see is going to be called acetabulum, where the head of the femur joins to. We see the body of the ilium, the largest portion, iliac crest, forming the superior margin. And we'll talked about that opening already earlier on, pubic symphysis. Joining the pubic bones together. We talked about how that actually separates when you go into labor. So a bunch of good stuff there, sciatic notch, greater, lesser, things like that to notice. In terms of the lower limb, let's keep up the speed just to be respectful of your time. Let's have a look of femur, only bone of the thigh. It's in fact the largest and strongest bone of the body. Some parts to know, we see again the head portion that articulated with the acetabulum of the hip, neck, which is the part that can get fractured. So that's something to keep in mind. And we see greater trochanter and lesser trochanter, major muscle attachment sites. And then we see our condyles and epicondyles at a distal and lateral and medial ones. And between those, we'll see also a fossa. we'll see the site where the patella articulates there as well. Looking at the other bones, the leg portion, let's highlight from there are tibia and fibula. Tibia is the medial one, carries the weight of the body from femur to the foot. Some portions that you could highlight, the condyles medially and laterally. And again, notice how tibia and fibula articulate with each other, both on proximal and distal ends. Fibula instead was the lateral bone, does not really carry weight. Similar terms, head and lateral bumps. Interestingly, there is a connective tissue band separating the anterior and posterior side of the fibula and tibula, and that's going to make sense once we talk about the muscles, how they come in pairs as flexors and extensors, and so on. In terms of the bones of the foot, the tarsals are really the ankle bones. Then we have our metatarsals, 5 of those. We have 7 tarsals, and then 14 phalanges. Remember, hallux was our great toe, big toe. So a bunch of things there to notice. So that covered everything about that bones chapter. I do have a little bit of a lighter chapter then to share with you when it comes to the joints. So let's, if no one has questions, kind of just fly through that. So we're talking about articulations. So really sites where 2 bones or more bones than 2 come together to form a movable junction. Their function really has to do largely with that mobility, creating the movement, but also holding the parts of the bones, holding the parts of the skeleton together. We can classify joints either based on their structural characteristics or their functional characteristics. When we classify structurally, what we see, we have 3 main categories: fibrous joints. This means that they don't really move a great deal. There's fibrous connective tissue involved, connecting the bones that are in really close contact. Some of the examples that I can think of, we talked about the sutures of the skull. So these are really rigid and interlocking junctions that we see there. We could also talk about syndesmosis, which are bands of connective tissue, kind of connecting the 2 bones together. I think we saw a good example of that with tibia and fibula just a moment ago, or we could see also an interosseous membrane. And then we have finally also gomphosis. My screen doesn't fully show it, so I'm not going to highlight it all together because I have other screens popping on top in terms of running this session, but kind of pegging a socket, kind of a joint. Really good example would be, for example, the teeth and the root of the teeth. What else can we talk about? We can talk about our cartilaginous joints. Here we have 2 bones that come together, no really joint cavity. They are immovable or very little movable joints. Examples: growth plates, pubic symphysis, and costal cartilage, for example. And finally, my favorite one, and probably the most important one, which is our synovial joint. Typically, what I do with synovial joint is that I sketch it with the students. But what I was going to do this time around was I was going to stop sharing this screen and instead hope that you can see this diagram that I put together. And I'll try to upload it to the Canvas if I already haven't. But we'll see that synovial joint is really a free-moving joint that is probably the most complex one of these that we'll see. Some parts, we see the 2 bones coming together and being separated, or kind of the bone ends covered with articular cartilage, which is hyaline cartilage covering the ends of the bones. We also have our joint cavity, synovial cavity, which is forming the actual space. We have our joint capsule, the actual capsule made of 2 layers. Fibrous layer, which is more external, and synovial membrane, which is the more inner. We can also see the synovial fluid, the actual fluid inside, that serve few different purposes, lubricating and also nourishing these structures. Remember, there's no direct blood supplies to many of these parts. We'll see a bunch of different ligaments reinforcing the structure, also nerves and blood vessels. These allow us nerves to sense the pain, position, stretch of a joint. Blood vessels obviously carrying the nutrients, gases, wastes, things like that. Other things that we can see on this sketch is also our fat pads, kind of providing a little bit of cushioning, articular discs, especially menisci, kind of improving that fit of the two bones, stabilizing it, and reducing to a certain extent wear and tear as well. And then we might have bursae, which are bags of synovial fluid also in the joint capsule itself, reducing the friction. So a bunch of things in terms of synovial joint, and that's why synovial joints are so important for us and are so worthwhile to know about. Let me see if I can share again my presentation now that we've had a look of those. Let me see, is it showing up? You should be able to see the presentation again. We can also do the classification based on kind of the movements that we're generating. Some good ones to consider are plane joints or gliding joints, where we have the just bones sliding past each other, gliding. Hinge joints, which are more like hinges. You can think of the hinges of the door. Pivot joints, where we have the end holding still and then rotating. Condylar joints, which are kind of more like oval socket, but not quite like a ball and socket, so not quite as good of a fit. Saddle joints, which kind of sits well and fits well, but there is limits to how much movement can take place. And then obviously our ball and socket joint that we saw a good example when we talked about, for example, of the shoulder joint. So a bunch of things in that classification. We could, I guess I could go back to this slide also to talk about the functional classification. Oh, let me go back. Functional classification when it comes to the fact that we can talk about, are we seeing no movement at all? These are immovable joints. For example, your skull bones would be good ones, or slightly movable ones. I think ribs are a very good example of that breeding. Freely movable ones, well, shoulder, hip, large range of movement characteristic for those. So I think that brings us, we did talk about osteoporosis before. Osteoarthritis would be another one to talk about, but in the interest of time today, I think that I'll leave it there. And that brings us to everything I wanted to say about the chapter material. So now that we've had a look of that, let me just dig out the question that was asked about the curvature of the coccyx. So let me just place this away. Just gonna log into our publishers platform. And I'm just scrolling through to pull up this week's assignments. My view looks a little different, so that's why I don't want to bore or overwhelm anyone. Let's have a look what we can find there. I don't doubt your question. I just want to be sure that I provide a good answer, not just like so answer. I'm just going through the questions, trying to find the one, well, I guess that I can share them going through, and that gives a chance for anyone who's been here to at least see something that might be worthwhile. So let's see. The question was about coccyx, so I'm going through the questions just to find the correct one. Because it is worthwhile to notice they might come up in the in your test. So that's why I want to make sure that I give you a good answer. It's probably a little bit further, but since we're going through them one by one, we'll just go until we find there's a question about the pelvis characteristics. I'm trying to see if it was this question. So we would see the male and female pelvis differing, the pubic arch less than 90 degrees on males, the heart-shaped pelvic inlet. So remember the opening. On females, it's more of a round shape. On males, it's more of a heart-shaped, narrower pelvis. Round obturator foramen, shallow, and female shallower, lesser pelvis. Coccyx movable and tilted posteriorly. So that's probably what you were talking. So if we think of the coccyx and the baby is going to come out, we want to create as much space as possible. So that's why the coccyx would be kind of pointing more posteriorly so that we're not limiting that birth canal, which the baby has to come through. So I think that that's what it's referring to. Anterior pelvic tilt, shorter sacrum, wider sacrum, wide greater sciatic notch, anteriorly facing as it balloon. So I hope that that's what you were looking. Jason shared kindly that on the page 75, on section 8.5, you can find a lot of information about that. So let me see. I'll pull that up as well with the hopes that that's helpful. Let me just get the textbook. I have to be a little bit of, they've asked us to be respectful, not to share everything with students that we have the view. So I'm just pulling our textbook up. I really do encourage this textbook available for you. I know many of you are incredibly busy in your day-to-day lives. If you're, for example, like me, and you end up spending a lot of time in a car, I commute from Tucson to work at the Chandler Gilbert. So I sit a lot in a car. You can actually have the textbook read or have the system to read the textbook aloud to you, like as an audio book. So that might be one way to approach learning this. So let's go and find the skeletal system. And I'm trying to look at, said that it was, sorry, I'm clicking around. Figure 8.5. So I'm just going to go through it this way. Let's see if there's a nice explanation on the a little bit further. We find the diagram. So the differences between the meniscus, there's a question on the chat. So let's have a look at that in just a second. I hope I didn't go too far. So this was this one, let's see. 8.5, the comparison of the male and female pelvic girdles. I believe this is on page 255 or whatever version you have, then you'll use that version's pages. Oh, let me get this working. 255 was the page. I think that this table will be useful for you comparing that differences between males and females. Would we expect you on this course to be able to tell whether it was a male or a female based on the skeletal remains? That is a specialist skill that you learn and that you gain over the time. So I probably wouldn't say that you would have to be certain about it. Would we like you to have at least considered that a little bit? Probably yes. But again, remember, people train for years and years to do skeletal analysis at the postgraduate level. So if you just have a general appreciation, you're probably doing pretty good. So that might be a worthwhile pages to pull up. So consider that. Just put that section. And I'll share this also as an announcement, because my thinking is always that if a student asks it, one student asks it, there's been multiple students who have been thinking about it. So hopefully that's helpful. And then there was a really good question also on the chat. Let me just, difference between the meniscus. Are there tricks to help? Good question, Anderson. Again, I think this goes a little bit beyond of what I would expect from you. I'm happy to unbundle it with you, though. So this is by no means to say that, no, I won't help. Let me think of that a little bit. What would be a helpful way to draw comparisons? So I'll think about that a little bit, and I'll share an answer on the announcements later today. I'm kind of, my initial response would be that even as anatomists, we sometimes struggle, because one of the things that you'll get to notice pretty soon, more you study A and P is, and especially, and I kind of feel bad that we don't get to do it on this course, but especially once you get to do dissections of the cavaters, human cavaters, is that you can dissect things in many ways and reveal different structures of the body based on how you dissect it. So it was only about 15 years ago that we found one more meniscus within the knee joint. So we had always just dissected knees in a certain way, and then a group of researchers started dissecting the knee joint a little differently, and they realized that, well, actually, these connective tissues form a different band than we had initially thought. And obviously here, the other thing to bear in mind is that you're learning, and I know that it's a little bit of annoying when you're learning it now, is that you're learning averages. In reality, there's far greater variation from one individual to another. Certain connective tissue bands are more pronounced than others, also based on how you have used your joints and so on. So like I said, let me think about that a little bit, and I'll send an announcement kind of trying to clarify that. I think that the directional terms are the key there to kind of tell them apart. That's where my initial hunch or initial answer would go to. But like I said, I'll share a response to that on the announcements. Does anyone have any other questions for the good of the order? Well, in that case, we have covered everything I wanted to cover. I'm really, really grateful for you for being here. And like I said, I'll share those extra credit points. I normally put them to your discussion score, so it might be later in the week or at the very beginning of the next week. Please rest assured that you are covering the material to a great standard. And again, choose what works for you, utilize resources that work for you, and utilize assignments that work for you. That's why I provide a lot of them and a lot of variety, so you can kind of draw what's beneficial for you. But that's all I had planned. I'm happy to stick around, happy to answer to any other questions, happy to talk in general. But if you don't have anything for me, that's all I have for tonight. I hope you have a good weekend and you get to enjoy it as little bit, because next week it's going to be a lot of material again with the muscles. Thank you so much. And I'm going to stop the recording at this time. Like I said, please remember that even though this is a virtual course, online course, an asynchronous online course, it doesn't mean that you wouldn't have support. I am here to help you in any way that I can. So don't hesitate to message to me. Don't hesitate to let me know. I think we saw some good examples today. When you have questions, I'll try to find resources to highlight those and provide clarification. Also sharing good stuff, sharing things that are maybe a challenge, sharing personal experiences, all of those discussion forums is a great place for that as well. And as always, if you don't hear back from me, don't hesitate to resend the message. I normally ask that you communicate with me through the Canvas. I know I have at least one email that I've got to answer to. I do answer if you send me an email, but it might be a little longer turnaround because I just get so many emails. I always prioritize my students, and that's why I prioritize the Canvas messages. But that brings this session to an end, and I hope you have a good weekend, and don't hesitate to reach out to me how I can help you. Until next time, thank you and bye.